Thank you for joining us today for another fabulous presentation that's part of the wonderful KT Canada Summer Series. Today, it's our privilege to have Dr. Andrea Tricco join us, and she will be presenting on the co-creation of knowledge synthesis with knowledge users. I will just like to explain briefly about the procedure for questions for today's session. If anyone has a question, please let us know by sending the question to everyone in the chat. So please choose the everyone option in the chat. And Megan, our moderator, Megan will also, and I collectively will help to address any questions, share the questions with Dr. Tricco. And now it is my pleasure to introduce our presenter, Dr. Andrea Tricco. Her bio is very impressive, so bear with me while I share some of the important highlights from her career. Andrea holds a Master of Science in Epidemiology and PhD in Population Health. She's a scientist and director of the Knowledge Synthesis Team in the Knowledge Translation Program of the Li Kai-shing Knowledge Institute at St. Michael's Hospital. She's also an associate professor at the University of Toronto in the Dalai Lama School of Public Health and Institute of Health Policy, Management and Evaluation. She's also a co-director and adjunct associate professor of the Queen's Collaboration for the Healthcare Quality Joanna Briggs Institute, Center of Excellence at Queen's University. Dr. Tricco has published over 300 peer-reviewed articles and holds a Tier 2 Canada Research Chair in Knowledge Synthesis. So it's my pleasure now to turn over to Dr. Tricco for her presentation, and then I will return to help shepherd some of the questions at the end of the presentation. Thank you.
Great, thank you. It's so nice to be here today and so great to see so many friends here online today. Thank you for joining, and thank you so much, Allison, for that really lovely introduction. So today I'm going to be talking about a topic very close to my heart. So something that I've been working on for the past 12 years or so. So how do we co-create knowledge synthesis with various knowledge users? Before I get into it, I would like to acknowledge the land that the central team works on, or that my research team works on. So it's now known as Toronto or Toronto, and it's the traditional territory of many different groups. So we have the Mississaugas of the Credit and the Chippewa Ojibwe of the Anishinaabe, as well as the Haudenosaunee and the Wendat. And I'd like to personally honor the elders and knowledge keepers, both present and past, and also to say that I personally am committed to continuing to learn and respect the history and culture of the communities that have come before and presently reside here. So have personally taken cultural safety training, the SANIA's training, as well as the University of Alberta Indigenous Canada training Coursera course, which I would highly recommend to everyone. And this helps us to learn about and acknowledge the harms of the past and present, and dedicate ourselves to work and listen to First Nations, Inuit, and Métis communities in the spirit of reconciliation and partnership. So in terms of my disclosures, so I do receive stipends. So I have given a similar talk to the Canadian agencies of for drugs and technologies in health, and also I do receive some funding from the Journal of Clinical Epidemiology as an associate editor. I do hold a Tier 2 Canada Research Chair, as Allison mentioned, and that I am the nominated principal investigator for the CIHR funded Sport Evidence Alliance. So you can take everything I say with a grain of salt, because I'm very biased about this topic, because it's what I've been working on for a long time. Also, I'm an unpaid member or associate editor of other journals as well. So hopefully by the end of our session today, we're going to talk about, hopefully you'll be able to describe or explain how to use co-creation in the knowledge synthesis process and how to engage with patients and other partners or other knowledge users in knowledge synthesis, and how do we show our appreciation for patients and others, and evaluate and report patient and public engagement, and then how do we embed equity, diversity, and inclusion in the knowledge synthesis process. Oh, I don't know what happened there. Okay, so co-creation. So what is co-creation? So this is a definition that I used from Trish Greenhall and All's paper. So they did this literature review and case study. And so they define co-creation as the collaborative generation of knowledge by academics working alongside stakeholders from other sectors. So there are many different terms that are used and definitions, and I'll talk about this actually on the next slide. So we hear things like co-creation, co-production, co-design, and the concept is found in other sectors. So we see work on this in business, management, design, science, etc. And when we think about co-creation, the spirit really is to invite a multidisciplinary and diverse partnership across different types of members, and we're inviting them as equal members of the research team. So we're trying to produce research alongside researchers and other partners and create a sense of ownership by everyone on the team. So by working together towards this common goal, the sum is greater than the parts. So the whole spirit of co-creation is that when we're working with our different partners, we're actually going to have a better project. So it's going to lead to better science and better research when we involved many different partners on our team. So the different definitions were recently looked at in this scoping review of 979 articles. So they found 8 prominent clusters of definitions, and these were applied in health and social care. So the different clusters had to do with what were the origins of co-production, what is the value created with co-production. I'm talking about patient engagement here, so citizens or community members involved in public service provision, community service user and provider relationships. So again, talking about the diversity and partnership that happens. Thinking about having service delivery as a core element of the project, thinking through the values and principles of co-production, what are the components of co-creation, and also thinking about experience-based co-design. So using your experience to continue with designing whatever you're working on together. So there's been quite a few papers written on this. I was a little surprised when I saw this scoping review, almost including 1,000 articles. So definitely an interesting read on thinking through all the definitions, and you know, I think something that comes from this is kind of defining it for your team and figuring out, you know, what does this mean for you? Because there's been a lot written out there, and it would be good to think about that on your team. So how is this related to knowledge translation? I know there's so many experts here on the phone, so or on the Zoom today, so I'm probably preaching to the converted, and you probably could do a better job of this slide than me. But just to say that there are 2 types of knowledge translation. So we have end of grant integrated knowledge translation. I really like this article that was written by Janet, Audrey, and Ian. So this is really great because they're talking about community-based participatory research and the relationship between that and integrated knowledge translation. So we need all types of knowledge translation, and when we think about co-creation, it really is the closest to integrated knowledge translation. And again, you know, we're trying to work together with a common aim of co-creating. We're creating this research project, and the sum of everyone working together is much greater than researchers working in silos, or on the flip side, our knowledge users working in silos. So in terms of the evidence, because I'm talking to an evidence-based crowd here, why is co-creation important? Or, you know, what is some of the value add for co-creation? So this here is based on a systematic review, and they included 24 studies. So there were quite a few qualitative studies in there. There was also some case studies and protocols. So you know, the evidence may not be, you know, the strongest. However, there is a lot of evidence anecdotally and based on these qualitative studies showing, and case studies, showing that co-creation can improve the consistency in clinician assessment. It can identify problems that were previously missed. It can actually change the clinical pathway. There's some evidence of reduced hospital visits and admissions, as well as patients who fail to attend appointments, and really importantly, increasing patient satisfaction. So there is an evidence base showing that this is important. And here are some studies that were included in the systematic review that points towards that. And so some of the principles are using more of a systems perspective and thinking of this as being non-linear, and also trying to adapt it locally to the problem that you're trying to solve, and framing this as a creative activity focusing on human experience. So in science, oftentimes we're taught to be very objective and, you know, not focus on the relationship or, you know, focus on getting things done and whatnot. But this, you know, go into this with the intention that this is something creative that you're doing, and it really is about the relationship and human experience. And again, feeding into this, you know, thinking about the quality of the relationships, power sharing, and also perceiving if there are disagreements on the team actually as something positive. So that's actually going to advance your work and come up with better answers. And so you want to make sure that you have some trust-related mechanisms built in, and I'll talk a little bit later in the presentation about trust and the importance of that, and some mechanisms to foster that. And you want to always come from a creative, flexible, and iterative approach when you're using co-creation. So I will touch briefly on knowledge users. So these are typically your end users, and we usually think about three categories. So patient and public partners, healthcare providers, and policymakers. And the goal is to engage all three of them in your research study. So I'm not trying to be overly prescriptive. That being said, just based on experience, there is great synergy and great power when you have the diversity in your knowledge users. So you want to invite everyone to come together, and everyone is going to be a co-author on this project. So you have researchers, patient and public partners, policymakers, and healthcare providers. And the value in doing this is just, based on my lived experience, is phenomenal. So that's what we're trying to move towards. And of course, that may not necessarily make sense for every project. However, come from a place of possibility and thinking through, like, would it be possible that for all of our projects that we can include this diversity in our knowledge users. And just also to note that knowledge user is a more inclusive and culturally safe term than stakeholder. So I try not to use the word stakeholder because it might not be a culturally safe term. I think we've used it quite a bit in the literature. And so I, you know, it's an easy term for people to remember. People like using it. For me personally, I try to use knowledge user, end user partner, or research partners so that I could be more inclusive and culturally safe. So we did a scoping review a few years back on different ways to engage with knowledge users. So they can be engaged. So this was actually a scoping review based on 84 studies. So when we looked at these articles, we saw that 36 of the articles engaged with knowledge users at the conceptualization and design stage, and then 38 engaged with them at the search and data collection stage, and 52 at the data synthesis and interpretation stage, and then 32 at the knowledge dissemination and application stage. So we saw that the bulk of the engagement within knowledge synthesis had to do more at the back end. So thinking more about the data synthesis interpretation more than anything else. That being said, you know, we did see quite a few studies that didn't engage with knowledge users at various stages, which was really great. And in terms of the roles of knowledge users, there's many different ways that these articles did this. So whether it was through key informants, whether it was through like an advisory group or working group or expert panel, and then some of them had a combination. So we kind of teased out the different ways, the different roles that knowledge users had in the scoping review. And the engagement method varied as well. So sometimes they did surveys, focus groups, sometimes they had Delphi, sometimes they also did document feedback or had meetings or workshops. So quite a few different ways of engaging, so different methods. And then the modes were things such as in person, through the phone, email, online, etc. So again, we tried to break that down according to the stage of the knowledge synthesis process. And so we came up with this nice little diagram of giving suggestions on ways that we could do co-creation and knowledge synthesis. And again, you know, the goal is try to do it at all the stages. That being said, we know that these, you know, this takes time and energy to do this. So do the best you can. And so, you know, be very mindful and thoughtful about what stage would make the most sense for your knowledge synthesis project. So at the protocol, we can engage with our knowledge users to refine the questions, define our eligibility criteria, even help us select the review method. So we can ask them, you know, in your opinion, would an answer to this question be better if it was, does this intervention work? And if they say, yeah, we really want to know if this program or intervention works, then maybe we should do a systematic review. Or if they say, you know, we don't really need to know at this point if it works, like this is just an area we're so unfamiliar with. We just want to know what's been done, what's out there. So then perhaps a scoping review method would be most appropriate. So you're going to work with your knowledge user to even select your review method. For the literature search, they can help refine terms. They can also supplement the search results. So when working with knowledge users, I like to ask these individuals, do you have any seed studies that really answer your question that you're really excited about that you can share with us? Because we could either use those studies to build our eligibility criteria, we can use them to develop our search strategy, or we could use them to even test our search strategy. So I usually ask for some articles that they felt were relevant to their question. Screening, so we can ask them for their feedback on our screening question or eligibility criteria. Again, we can get invaluable feedback on that to figure out exactly what they're looking for including. Again, on our data abstraction form, so which data items would be most relevant to you. We've even had experience where the knowledge users got involved with screening, data abstraction, and risk of bias appraisal, or we sent them the cleaned data and they've told us whether we hit the mark or not. For some of those complicated topics, we've had invaluable feedback from knowledge users doing that. They can help us with interpreting their risk of bias. Sometimes they say, you know, the tools out there are not really helpful. Can you supplement your risk of bias appraisal with this tool? Can you do a grade appraisal for us as an example? The grade summary tables could be helpful to some knowledge users. So we tailor all of that according to what their needs are. And again, as you saw in our scoping review, a lot of studies or a lot of reviews get knowledge users to help with the analysis, interpretation, and contextualization of findings. Sometimes we ask our knowledge users to draft one-page lay summary, so it could be also a policy brief as well. And this would be to think about our key messages. So instrumental in helping us with that stage of the process as well. And so I just wanted to present some case examples for you. So here is a systematic review that we had extensive co-creation with. So on the authorship team here, we have researchers. We actually have 4 policymakers from the Public Health Agency of Canada. We have 2 clinicians on the team and a patient partner as co-authors. So this is a paper that I'm like really proud of because it took something to do this. And it was great. Like I'm very happy with the paper. Like it led to very rich interpretation. It was just amazing to work together with the diversity and partnership. We also had 2 trainees as co-authors, and we were all involved with everything. And from the very beginning, we said, this is something we all want you to feel ownership and be proud of. So this is something that, we want your feedback at every single step. We want you to feel that, again, the sum is greater than the parts, and that we're all working together towards something collective. So this for me is like so amazing, because I love relationships and working with people, and that's just my style. So this was a real highlight in my career so far, this paper. It wasn't published, it was published in BMJ Open. So, not the journal with the highest impact. And to say that it really was a huge highlight for me in my career. And so we had our knowledge users involved with conceptualization, with the literature search terms, study eligibility, data items, interpretation of the results, and also they sent us a lot of revisions, especially our colleagues from Public Health Agency of Canada. It was a lot of back and forth. It took a while, but again, something I'm incredibly proud of. And just to say, we're currently working on another similar project right now, looking at the influenza vaccines in older adults, and it's actually a network meta-analysis, which is a very complicated knowledge synthesis, and it's a complex topic. And our knowledge users, we also have a patient partner on the team, very excited about that. We have clinicians, so we have infectious disease specialists on there as well. And the Public Health Agency of Canada is like so involved, and they're telling us like, they actually did the pilot test with us, like they confirmed all of our included studies, we're sending them the data. Like, anyways, it has been a really incredible experience. So here's another case example. So for here, we have researchers and clinicians as co-authors, and we also have a trainee co-author. So in this one, we did work with knowledge users from the Public Health Agency of Canada. So we worked with them, but it was more like a consultant kind of relationship. So, we would go to them, they would, give us some feedback, and we kind of go off on our way and continue to check in with them. So they did check in on various stages, but it wasn't that same essence as the previous project. So it wasn't like, this was a co-ownership thing. It was kind of like, here's the question, we need evidence for this, you go off and you can consult with us, and we're not interested in being co-authors. So it was a great project. And just to say as well, for this one, we didn't have any patients or public partners engaged with this project. And then this is a minimal co-creation. So this was published 10 years ago. So we have researchers, we have clinician scientists who are, very well informed on this topic. We didn't have any policymaker, knowledge user involved, or patient or public partners or trainees. So just to show the progression in the last decade and the types of partners we're working with and the types of questions that we're answering, and different types of knowledge synthesis that we've been doing. So we've come a long way in 10 years. So I've been going on and on talking about how amazing co-creation is, and that, everyone needs to be doing this. But I would not be a good scientist if I didn't tell you that there are some challenges. So we also did a scoping review on, actually, I think I mentioned it previously, engaging policymakers and health system managers in the knowledge synthesis process. So we also charted the barriers and facilitators here. So 16.7% of the articles, and this was reported in 31 studies, the different factors. So about 17% saw knowledge user expertise as a facilitator, whereas, and then when we look at the second largest facilitator was early relationship building. So again, getting to the relationship piece. And then the biggest barrier here was time. So about 11% said time. Also, some felt knowledge user expertise could be a barrier. And then we also had forums for interaction as a potential barrier. I mean, this was published a few years ago, so it'd be interesting now to see. We've all gotten used to this online Zoom world, so it would be interesting to see if that number would change. Just based on my own experience, The relationship building is the big thing, and the only way that we can build relationships is through communication. So that to me is really huge, and taking the time to communicate and remember to communicate is something that even I have to work on, and something that is so important in our projects when we're trying to do co-creation. And we wrote this nice paper about engaging knowledge users in scoping reviews. So we have more tips on there. So things such as developing a plan for engagement, and there are many resources out there that I could point you towards on how to do that properly. Ensuring that you have appropriate resources, which I'm going to come into in a few slides, providing capacity building for everyone. Sometimes, I don't know if I'm sure people here, we have a lot of experts on the call today, so I'm sure people have had this feeling like, oh, are we really speaking the same language? And sometimes it takes a few meetings to even understand, like, oh, is that what you meant? That's happened to me several times in projects. So making sure that you understand terminology and that everyone's on the same page, and understanding, okay, a systematic review means this, and this is, what that means, and whatnot. So I think there's a bit of capacity building from the researcher's perspective as well as from the knowledge user's perspective. Developing recruitment strategies and also thinking about potential for turnover. Sometimes these positions are not held on to very long. So thinking about that, how long is your project, and developing a plan for that. Considering potential barriers and how to overcome that, trying to create a positive environment. And I'm going to spend some time talking about that at the end of the presentation. Showing your appropriate appreciation, and in particular for patient and community partners that I will talk about as well, is just so important. And making sure that you report your engagement transparently, and then also evaluating it. So definitely, if you're interested in learning more about some tips that we have, I would encourage you to consult this paper as well. So now I'm going to move on to patient and public partners, because I think it's really important that in all of our knowledge translation and knowledge synthesis efforts that we engage with patients and public. So I use this terminology, and so this is because this is what CIHR calls it. If you go all around the world, you're going to hear community and consumer engagement. You're going to hear patient and public involvement. You're going to hear a lot of different community involvement, community engagement. There's a lot of terms. The reason that I use these terms is because that's what CIHR uses for right or wrong. And I'm in Canada, and I'm a Canadian researcher, so I usually try to follow what CIHR tells me. So their definition of a patient is an overarching term. It's inclusive of individuals with personal experience of a health issue, as well as informal caregivers, including family and friends. So it's very inclusive terminology. And when they talk about patient engagement, this is focused on meaningful collaboration. So they become partners in the project. They can be actively engaged in everything, really: governance, priority setting, even nominating the research question, performing parts of the research, and even co-leading it. So with our Spore Evidence Alliance, which I won't spend much time talking about today, but I think I saw Heather Cahoon on the call. So she's leading one of these amazing projects where she's actually co-leading a project with a patient partner. And so she's been part of 3 pilot projects, which has just been really incredible. And we have more on that on the Spore Evidence Alliance website if you're interested. But Heather has a lot of teachings and learnings based on doing this properly. So I would say even here, we could even add co-leading the research as well. And then oftentimes there's some confusion between, okay, what's patient engagement and what's patient-oriented research. So patient-oriented research is a continuum of research that engages patients as partners. It focuses on patient-centric priorities and improves patient outcomes individually, as well as in communities such as vulnerable populations. And what I like about this definition is that they highlight the multidisciplinary nature of teams. So I think that's really fantastic. And the goal, again, is to improve health system and practice. So kind of touching here on that the sum is much greater than the individual parts. So why do we care about this? Well, 50% of patients don't get the treatments that have been proven to be effective. 25% get care that is not needed or potentially harmful. And so we spend $8,019 per person in 2021 here in Canada. And so patients as well as clinicians have a right to expect that important health decisions are made. And so this is why CIHR introduced SPORE, and that's what the whole SPORE is trying to work towards, is trying to make sure that the right patient gets the right treatment at the right time. So that's all I'll talk about SPORE today. That could be a whole other talk in itself, but does give us some really solid rationale as to why we would engage with patient and public partners. So from the literature on rehabilitation, we've heard the term nothing, or the quote, nothing about us without us. So we want to do everything we can on every project to invite patient and public partners, include them on everything. They are decision makers. They have lived experiences that are unique. They bring a different perspective. They can also link us to other research partnerships, and it's a great way for us to learn as researchers as well as our trainees to learn. So just to give you a quick lived example, so we did a project for the Public Health Agency of Canada, and when we went to members of the community with the research question, they told us that actually the research question was completely wrong. And the research question was very stigmatizing for this group of patients. So we had to go back to the Public Health Agency of Canada and let them know, we've talked to the community and this question completely misses the point. Like, it just completely misses it. And also it's very triggering and stigmatizing. So if we didn't engage with the community in that case, we could be conducting research that is just not relevant, not important, and also further increasing inequities in our health system. It just shows how important it is to engage with the community and public partners, and how important it is to engage with them from the very, very beginning. And we have an obligation as researchers as being the bridge between these different knowledge users. And so we can actually take the information that we're learning from patients and public and bring that to our policy decision makers and do some capacity building with them and some learning with them. So I do think that we play a very strong role here, and that we can actually have such a huge contribution with this. So how can we bring the patient and public and community voice as close as possible to policy decision making for health systems in our country? That's something that's really exciting to me, and something that I think all of us as researchers can spend more time thinking about. So getting to the effectiveness of community engagement. So I talked a little bit about the effectiveness of co-creation. I was so happy and excited to find this systematic review and meta-analysis of 130 studies. And so they actually did some pooled effect sizes for the quantitative people on the line. And they saw that it is highly effective. And they were actually looking at health inequities as well. So really great systematic review here. So they found positive impact on health behaviors, health consequences, self-efficacy, as well as social support. So for individuals who are researchers here on the line who are curious about community engagement and wondering like, does it really work? The answer is yes, it is highly effective, and definitely we need to continue on this route. And so in here, they tried to tease out different types of components of these interventions, which would be considered complex interventions. So they found that those that engaged the community in the delivery of the intervention had a very, actually one of the largest effects. They also found that any intervention that adopted self-mobilization, design collaboration, or design consultation theories of change, whether the theory of change was implicitly or explicitly stated, they had similar effects, but these were actually lower than lay-delivered interventions. So again, coming up with the real importance that these interventions are co-created with community and with patient and public partners. And not only are they co-created, but they are actually delivered and implemented by the individuals that come from that same community. They also found that interventions that did not fit into one of the 4 main theory of change categories had the smallest effect. So again, you know, the importance of considering theory when you develop your intervention. So making sure that you use the theory of change when you develop your intervention, you're going to have a larger effect. Something that was interesting that kind of went against, you know, what I've been taught or what I've seen in some of the research that we've done on complex interventions was that single component interventions seem to have higher effects. So this is something that I think, you know, we could tease out further. This was published in 2015. So definitely something that, you know, I think we could do more on, and thinking through, you know, what are the doses and what would be the specific combinations of interventions that would be more or less effective when it comes to community and patient and public engagement. And I really like this framework. I'm sure many people are familiar with it. So this again is from a systematic review. So this is by Shippey and colleagues. So they did a meta-narrative review of 200 sources, and they proposed this 2-part framework when you're thinking about patient engagement with service users. So this would be things like the patient and service user initiation, building reciprocal relationships, realizing it's a co-learning process, as well as reassessment and feedback, and using that feedback to always improve everything that you're doing. So that's something I'm going to touch on in a few slides, but just to plant a little seed in your head that if you are doing this work, you really have to evaluate what you're doing. And so here they have the different phases of research. So this could be applied to knowledge synthesis or any type of research project. So thinking through all the different phases, and then thinking through how you could do different types of engagement and different tasks that you would use. So definitely a nice framework to think through when we're working with patients and with the community. And here is a narrative review by Harrison and colleagues of 55 studies. And I love, love, love their framework here. So their framework has these foundational principles, and how nice would be to set those foundational principles as a team when you're doing a co-creation type of project, right? So coming from a place of respect and equity. So thinking about diversity, being authentic, thinking about integrity, as well as confidentiality. Coming from a place of trust, so transparency, honesty, as well as empowerment. So shared decision-making, also making sure it's flexible, also making sure that you have institutional support. And then they have these best practices. So research, training, and education. So, you know, this goes both ways. Like, I think, you know, oftentimes as researchers, we think, oh, we have to train the patient and public partners, but really in my experience, we have to train the researchers on how to do this properly, right? So this training and education goes both ways. What is the role clarity? How do you appropriately match researchers and the community together? How do you, ensure appropriate budget and compensation? So this is something that's huge that we have to think about when we're embarking on this work. Also thinking about the evaluation, right? So making sure that you're ongoing monitoring and evaluating your engagement. What is your overarching engagement structure and model? So how will you plan to do this? Will you have patient partners embedded in the project or have an advisory council? How will you conduct the research team communications and meetings? So again, something you need to negotiate and think about at the beginning, as well as engagement, sustainability, and reinforcement. So you might be all excited at the start, but how do you sustain this, and how do you reinforce this as things go on? And again, this is across the different phases of research. So I just love this framework, and I think it covers so many of the important pieces when it comes to this work. So this is from a friend and colleague, Dr. Richards. I'm sure many of you know her. So she's done just some phenomenal work, and she and I have given similar talks on that I'm giving here with you today. So huge shout out to Dr. Richards. She's amazing. So she wrote this really fantastic article on compensation. And the issue is that if we're all getting paid as researchers to do this project and to do these to do this work, we really want to make sure that we're compensating our patients and community members properly. You know, we have co-created an appreciation policy with patient and public partners. That to be said, some patient and public partners may not be happy with that policy that you co-created. So perhaps they have, like, for some things that we may not think about would be something like, some of them might be on disability insurance as an example, and so they may not be able to accept payment because then their taxes are affected. So, you know, we need to think about above and beyond that, oh, you know, I just need to pay them by the hour type of thing, right? So the best advice here is to talk about it. Communication, remember how I had that a few slides ago. So talk about it and ask, like, what would work for you? You know, like your contribution is so highly valued, you know, and I want to show my appreciation for what you're doing, and I want to be fair. And also, I don't want to create more inequities in the system by asking people to volunteer their time when everyone else is getting paid. So it is an issue of equity. It's also an issue of showing our proper appreciation. And I've worked with some patient partners who've said, you know, can you make a donation on my behalf? Or, you know what, no, just give me a gift card. Or, oh, can you buy me a laptop? Or, you know, can you provide this lump sum, or can you pay me by the hour? Again, you really have to tailor this according to who you're working with, and not everyone is going to answer the same. So this is something that's a huge thing that we have to think about when we're engaging in this work. So be open. Open communication is so important, and think about this and be very thoughtful about this, because again, we don't want to be contributing to more inequities in the system if we're asking people to volunteer, you know, so much of their time. So check out this article. I, you know, don't have time to go through everything in there, but some really great information in there. Also, Dr. Richards published an amazing paper on authorship and acknowledgement. So again, you know, we want to make sure that everyone is being acknowledged appropriately. Oftentimes we use the ICMJE criteria for authorship. On all the projects that we've worked with patient partners, you know, they have fulfilled authorship. There has been no doubt, you know, like so it hasn't been a question of that. So, and sometimes some patient and public partners don't want to be named. You know, there might be a condition that there might be some stigma with that condition, and they don't want people to know. They may want to remain anonymous. Again, you have to ask and communicate with them to ask them, how would you like to be acknowledged? Would you like to be a co-author? And be open and flexible with all of these discussions. So why do we evaluate our patient engagement? Because we don't want to be causing more harm. We don't want to be causing more inequities in the system. We want to improve our processes. We want to do better, right? So we want to make sure that this is a brave space for everyone to come together and collaborate together. So this was the peers. I'm not sure if Linda Lee is on the phone or if any of them are on here today, but just to say that this is an amazing tool. So this can help you evaluate your patient and public engagement. And then we did do it with the Spore Evidence Alliance, and we have a paper that Linda Lee led in the Facets Journal. So if you wanted to know more, definitely look into this. Again, you know, this is a continuous learning opportunity, co-creation, working with patient and public partners. So we always want to make sure that everyone's happy with the engagement, and that, you know, we're making people feel safe and welcome on the team, and that we're continuously evolving. We're continuously evaluating this. This was the GRIP 2 reporting checklist on patient and public engagement. This is another great way to report the different elements. So also something to think about if you are working with patient and public partners as knowledge users. Now I'm just going to spend a few minutes on ethics, equity, diversity, and inclusiveness. So I would argue that as researchers, we need to consider equity, diversity, and inclusion in every single thing that we do. So we are, you know, often including these multidisciplinary teams. We need to make sure that it's a safe or brave space for everyone to contribute. If we are trying to follow CIHR, so in their strategic plan, they are trying to reduce health inequities. So we need to make sure that, you know, we aren't exacerbating health inequities, and as researchers come together and try to work on this collectively. So I think everything we need to do has to come from an EDI lens. And so the Cochrane Equity Group, so a huge shout out to Dr. Vivian Welch. So this is a lovely framework that she worked on with others. So it's the Progress Plus framework. It's a really nice way to think about equity. And actually what we're doing in all of our knowledge synthesis projects now is that we're actually abstracting all of this information. And we're also trying to do advocacy for people who are running primary studies and trials, that they start collecting this. Okay, so this is a whole other area that I think we can do a lot more work in. And just to say that the Progress Plus is a nice framework as a start. So we wrote a nice paper here with Dr. Vivian Welch and others talking about how to embed equity in the knowledge synthesis process. And this was focused on guidelines and knowledge synthesis, but it could be used for any type of research. So this is a very nice framework. So it talks about at every stage of the research process, how do you consider equity? So considering equity on the research team. So who is on your team? Do they have training in cultural safety? Do they have training in trauma-informed approaches, right? So thinking about capacity building, team composition, thinking through about your question, do you have an equity focus? Is the whole question focused on equity? Do you have a sub-question or sub-questions focused on equity? Thinking through if this is a knowledge synthesis, are you targeting specific equity terms? Are you targeting specific equity databases? When you're doing your data collection, are you using Progress Plus? Or are you abstracting all of those variables? Are you using an appropriate sex and gender-based analysis when you're doing your analysis and interpretation? Are you reporting your results using the SAGER guidelines? Are you reporting them using the Prisma Equity? So again, if this is something of interest to you, check out this paper. And again, we try to provide very practical recommendations on embedding equity in knowledge synthesis. And the reason we're doing this is because we do have power imbalances on the team when we have this diverse range of knowledge users. So just a nice little diagram again. So thinking about your team, are they representative of the topic? Can you complete a self-reflective exercise? I'll show you that in a few slides. Is equity a focus or sub-focus? Are you using equity-specific filters and databases? Thinking about the eligibility criteria, you may have different equity dimensions there. Progress Plus, as I mentioned. One big thing when you're looking at the included studies, are they powered correctly for equity? So oftentimes when you're thinking about intersectionality and you're thinking about equity variables, the numbers get smaller and smaller and smaller. So have they powered for that properly? And then also thinking about your analysis and reporting it using Prisma Equity or the SAGER guidelines. This is a very nice tool, a little checklist that was produced by the Public Health Agency of Canada thinking about intersectionality. So this is thinking about the intersection of all of those Progress Plus variables, right? So people who have lived experience you may have multiple categories here in your lived experience. So this is a nice way to think about how you can integrate intersectionality in your research. So would highly recommend that as a tool. And so when we're thinking about EDI, so how can we do this from an operational standpoint? So you can co-create your values, guiding principles with the team, co-create your terms of reference. So this is even before your research project starts, right? Co-create policies. So thinking about patient partner appreciation, depending on the topic, there might be something to do with conflict of interest that you want to think about and talk about as a team. And we have this shared reflective exercise. It is in, I believe Megan is sharing the slides. If not, I'm happy to share them with all the citations here. So this was based on Dr. Sharon Strauss and others, probably many others here on the line, a knowledge translation grant that was funded by CIHR and thinking about intersectionality along when it comes to knowledge translation. So this self-reflective exercise positions yourself in terms of your own lived experience, an advantage or disadvantage you've had in your lived experience, and the position on the team. And the reason that we would want to do this is because we want to break down systems and structures of power and things that have led to systems of privilege and oppression. So this is a reflection to do by yourself. You don't have to share, you're not encouraged to share this with anyone else. But some of the things to think about is, is everyone on the team involved who could have been involved? Does your team reflect the makeup of the patient community or healthcare providers that would be impacted by this project? And who are those affected by the project area? What would they want to get out of the project, and how can you get them involved? So definitely something to think about. And again, this is for us to think to create a brave space. So if we're noticing on the team that some people are very quiet and they're not engaging, well, this could be because of systems of power and oppression. And so this is something to explore. And again, trying to make sure everyone feels comfortable and are welcomed to the brave space. And this was a really lovely framework. I think Dr. Sibley is on the line, so huge shout out to this. I think in this work, coming from a trauma-informed approach is so important, and something that I think we need to talk more about, because sometimes our patient and community members will be triggered just being in that research meeting with you. So I think we all need training, and I would be saying to myself, I need training in trauma-informed approaches. And I know Dr. Sibley and others are working in this area and have provided workshops, but I think it's something that is definitely, we all need to think about this. And they've produced this very nice framework valuing all voices. And so they talk about education and communication, understanding and acceptance, trust, relationship building, and self-awareness. So if you haven't read their article, please do. It's amazing. It was a real treat finding it. I was very excited when I found it. And again, we're doing this so that we can co-create together in a meaningful, inclusive, and safe environment with patients and communities. So definitely something else that we can train everyone on when it comes to doing research in this area. And I'm getting to my end. I know I'm running low on time, so I hope I'm not stressing you out, Megan, but I'm getting there. Just to say that when we work with patient and public partners, oftentimes they look like the same type of people. And so just being mindful to try to be inclusive and to diversify patient and public partners. So this was a nice guidance that was written by Academy Health to give you some strategies to try to work on this. And I would say, like, even with the Spore Evidence Alliance, when we did our evaluation, we found that, we didn't have as much diversity as we would like. So, and it takes something to do that. So definitely something for everyone to think about. So recap my objectives. I hope we were on the mark here, we were on target, and that by the end you're going to be able to describe all this. I know it was a bit of a whirlwind, but there was a lot of things I guess I wanted to say today. I do want to give a huge shout out Dr. Dawn Richards, friend and colleague, Dr. Amanda Doherty Kirby. We've given similar presentations as well to trainees, Annette McKinnon, Catherine Stratton, Cy, Dr. Sharon Strauss, and Linda Wilhelm. I wouldn't be able to put this presentation together without all the learnings from these individuals, and I thank them, profusely for all the learnings and for collaborating with me over all these years. So that is it from me. Thank you so much. And I see that's been a little busy in the chat, so should I stop my share, Allison?
That would be great. Thank you, Andrew.
Great, thank you.
Dr. Tricco, thank you for such a wonderful presentation, both in richness in terms of both scope and depth. And personally, I was really happy to see in your case example, your first case example, the involvement of knowledge users in interpreting findings. That's probably a great opportunity that we don't always take the opportunity to include our knowledge users in that phase of the research cycle. So thank you. Now, there are some questions in the chat box. And as you can all see, there's 6 minutes left. So we will address the questions that we can, and any remaining, we will ask Dr. Tricco to address by email. Okay, so we'll begin with the first one, which was, thanks so much for this energizing presentation, Andrea. You do such inspiring work. Do you think that involving all knowledge users at all stages of the review is universally best?
Thank you. Yeah, that's a great question. I think it really depends on your purpose. It depends on who you're working with, the energy level that they have, and what the topic is on, right? Yeah, I think you really have to tailor it according to those factors. So prescriptive and say we need to do this for everything, but I would just say that, you know, the times that I have done it, it has been incredibly rewarding. I'm sorry, it says that my internet is unstable. Can you hear me okay?
We can. There's occasionally just a few moments of where it fades out, but it's just seconds. Okay. So yes, thank you.
Okay.
The next question is, I realize that this is a fairly practical question. For slide 20, is there any guidance on what methods, strategies are available for estimating appropriate resources?
So that was the slide about tips on engaging knowledge users.
Yes.
Oh, yes. Yes. Okay. So right. So the appropriate resources there's a budget calculator for engaging with patient and public partners by one of the SPOR, and the exact resource is escaping me. It would be in the references from the slides. So I'm happy. I don't know who asked that one, Allison, but I'm happy to email them that tool, the budget tool. And also in terms of planning for engagement, I believe it's the Saskatchewan SPOR has an amazing tool on planning for it. So I'm not sure, Megan, if you send around the slides or tools later, but I'm happy to include those 2 citations as resources.
Thank you. Next question. Great presentation, Andrea! Exclamation mark follows that comment. What do you think is the role of training in co-creation? If so, do you also, if you have any advice on engaging with policymakers?
Okay, so training or trainees?
Training,
I think, so I think that there's a lot of training that can happen. And again, you have to tailor it according to your time, your budget, you know, resources, whatnot. So I think first off is maybe it's not really training, but making sure you're speaking the same language. So coming up with terminology and definitions. So a bit of capacity building on that. I think as researchers, we can do training when it comes to co-creation in trying to create a brave space. So I think we can do, you know, our cultural safety training. I think we can do the trauma-informed workshop that I haven't done yet, but now I know I have to do it. You know, and I think that we can do some like our sex and gender-based analysis from CIHR. So there are things that we can do as researchers. I also think so with the SPOR Evidence Alliance, we've now had 2 cycles of patient and public partners do training specifically on rapid reviews was the first course, and then knowledge synthesis was the second course. So we've trained now about 50 patient and public partners, and I see Janet Gunderson is on the line. So huge shout out to Janet who co-led that the last 2 rounds. So we would provide training in that respect as well. So I think the capacity building would go both ways. And yeah, I'm hoping that I answered the question, Allison. Yeah.
Yes, you did. Thank you so much. Yeah. And just looking at the time here now, I really want to thank everybody for attending today's session. There will be the recording of the session and the slides will be available. So please follow KT Canada for those resources. The next webinar is planned for Thursday, December the 8th, and that will have 2 SPOR Evidence Alliance Seed Grant winners, Dr. Ghazal Fazli and Nicole George. So keep an eye out on the KT Canada social media avenues and newsletter for their presentation details. Dr. Tricco, thank you again. I love the terminology in the chat box about energizing. You not only provide comprehensive, but also compelling presentation. And we really appreciate the amount of time that it took in pulling all of this together, and what a great resource it will be for each of us to refer to when we're trying to up our games in incorporating knowledge users in our knowledge syntheses. So thank you all for attending, and lots of kudos in the chat box there.
Awesome. Thank you so much, Allison. Thank you for moderating, and thank you so much, Megan, for organizing and keeping us all on track. And thank you to this amazing audience. So my huge kudos to everyone as well. Thank you.
Thank you. Thanks, Andrea. Thanks, Allison. Take care, everyone.
Take care. Bye.